हैं पैथोलॉजी शॉर्ट 50 क्वेश्चंस. सो सुपर 50 क्वेश्चंस वी आर गोइंग टू डू. सो फर्स्ट जो हमारा है शॉक, क्लासिफिकेशन of shock. Then we have to discuss about septic shock, pathology, and also talk about anaphylactic shock. So shock शुरुआत करते हैं शॉक का. ठीक है. तो हमारे पास आ गया है द टॉपिक शॉक. ओके. सो शॉक के बारे में बात करते हैं. हमें बात करना है शॉक का डेफिनेशन, क्लासिफिकेशन, कॉजेस. देन इंडिविजुअली हम शॉक के बारे में बात करेंगे. ओके. वेयर इज माय पेन? एक मिनट. सो आई गॉट द पेन. सो लेट्स सी. ठीक है. लेट्स टॉक अबाउट शॉक. सो जो शॉक होता है ना, shock is a state in which diminished cardiac output or reduced effective circulating blood volume impairs tissue perfusion, leading to cellular hypoxia. Two things are occurring. One is hypoxia, other is impaired tissue function. Impaired tissue function. So two things are occurring in the shock. One is impaired tissue perfusion, other is cellular hypoxia. So prolonged shock can lead to irreversible tissue injury. Let's talk about causes of shock. There are so many causes like cardiogenic shock, hypovolemic shock, shock associated with systemic inflammation, neurogenic shock, anaphylactic shock, or septic shock. Okay. So these are the types. So talking about cardiogenic shock. So low cardiac output due to myocardial pump failure. This is the common one. So here the myocardial pump failure is there, like MI, ventricular arrhythmia, cardiac tamponade, pulmonary embolism. These kind of things are seen in the cardiogenic shock where the pumping capacity, pump failure is there because of the MI or because of arrhythmias, because of cardiac tamponade, or that is nothing but pericardial effusion, and pulmonary embolism. Low cardiac output due to low blood volume. Okay, so heart is fine in hypovolic shock. Heart is fine, but the blood volume is low because of the massive hemorrhage or because of the burns. This kind of shock occurs. Talking about shock associated with systemic inflammation. So inflammatory mediators from innate and adaptive immune system cells. Arterial vasodilation होता है, इस वजह से vascular leakage. So venous blood pooling. All the blood from the arteries and veins are coming into where? They are coming into the tissue. So because of the tissue hypoperfusion is there. There is a cellular hypoxia, organ dysfunction, organ failure, and death. Okay, so these things are occurring. So there is a tissue hypoperfusion. Because of that, there is a cellular hypoxia, there is organ dysfunction, there is organ failure, and death of the organ. Talking about microbial and non-microbial triggers associated with inflammation produces a set of clinical findings referred to as systemic inflammatory response syndrome. Septic shock is another type in which a microbial infection causes the shock. Okay, neurogenic shock. It is due to anesthetic accident or spinal cord injury. Anaphylactic shock due to IgE mediated hypertensive reaction. IgE mediated hypertensive reaction. IgE mediated hypertensive reaction. IgE mediated hypertensive reaction. There is a IgE mediated hypertensive reaction. Pathogenesis of septic shock देखते हैं. Pathogenesis of septic shock में क्या होता है यहाँ पर? Most frequently triggered by a gram-positive bacterial infection. There is a gram-positive bacterial infection. It occurs due to gram-positive bacterial infection. Okay, it is followed by gram-negative bacteria and fungi. फर्स्ट इन्फेक्शन किससे होता है? ग्राम पॉजिटिव. उसके बाद ग्राम नेगेटिव बैक्टीरिया एंड फंगाई आता है. ठीक है. फैक्टर्स दैट प्ले अ मेजर रोल इन पैथोफिजियोलॉजी ऑफ सेप्टिक शॉक. इन्फ्लेमेटरी एंड काउंटर इन्फ्लेमेटरी रिस्पॉन्सेस. जो इन्फ्लेमेटरी रिस्पॉन्सेस होती हैं, उसके बाद जो काउंटर इन्फ्लेमेटरी रिस्पॉन्सेस होती हैं. एंडोथेलियल एक्टिवेशन एंड इंजुरी, यहाँ पे एंडोथेलियम एक्टिवेट होता है, इंजुरी देती है। तो इंडक्शन ऑफ अ प्रोकोआगुलेंट स्टेट, जैसे प्रोकोआगुलेंट स्टेट जिस वजह से डीआईसी फॉर्मेशन भी होता है। देयर आर मेटाबॉलिक अबनॉर्मलिटीज, ऑर्गन डिसफंक्शन एंड अल्टीमेटली सीवियर शॉक होता है। सो यहाँ पे हम मेजर पैथोजेनेसिस ऑफ सेप्टिक शॉक देखते हैं, ठीक है। सो यहाँ पे है हमारे पास माइक्रोबियल प्रोडक्ट्स, okay, microbial products, pathogen associated molecular patterns are there, ठीक है। So what will happen, they activate the factor 12, complement activation is there, directly or indirectly, okay. Neutrophil and macrophage activation, of course this is there because of the infection. So what will happen, the complement activation either direct or indirect, they cause endothelial activation. This endothelial activation along with the neutrophil macrophage activation produces TNF, interleukin 1 and HMB-G1. Okay, this is causing the cytokine and cytokine like mediators releasing. And there is a factor 12 activation. Because of that, there is a procoagulant state in the body. So what will happen? Increase in tissue factor and decrease in tissue factor, TFPI. Okay, so there is a thrombomodulin. There is a protein C. Live. Okay, there is a protein C. Okay, protein C. So here antifibrinolytic and PAI1 will activate. So because of this platelet activation factor, what will happen? And here thrombomodulin decrease, protein C decrease, TFPI decrease, tissue factor decrease. What will happen here? There is a microvascular thrombosis leading to the formation of DIC, because of the tissue ischemia is there. Okay, here interleukin, so endothelium activation causes the antifibrinolytic effects, and interleukin 6, 8 and PAF and ROS activation, interleukin 10 and apoptosis and systemic effects. Here there is a fever, myocardial contractility, metabolic abnormalities, secondary anti-inflammatory mediators, immunosuppression, multi-organ failure, vasodilation, increased permeability, decreased perfusion, and here there is a renal insufficiency. Adrenal insufficiency. There is adrenal insufficiency. There is adrenal insufficiency. So here, if you see, what is there? Here there is a microbial product, because of that there is activation of factor 12. There is the activation of factor 12. Activation of factor 12, complement activation, either direct or indirect endothelial activation, neutrophil and macrophage activation leading to TNF, interleukin 1 and cytokine like mediators activation. After that, what will happen? The procoagulants are activated, because of the tissue factor will increase, TFPI will decrease, okay, thrombomodulin will decrease, protein C will decrease. Antifibrinolytic PAY1 will activate, and interleukin 6, 8, PAF and ROS will reactive oxygen species, they all activate. Interleukin 10, apoptosis, and STNFR will activate. Secondary anti-inflammatory mediators, immunosuppression. This is a fever, myocardial contractility, metabolic abnormalities, vasodilation. There is increased permeability, decreased perfusion. Vasodilation will occur, because of that there is a multi-organ failure. Okay, and here there is a tissue ischemia, there is a adrenal insufficiency, and there is a DIC formation. So here you will find severe vasodilation, permeability will be increased, perfusion will be decreased. In systemic effects, there is a fever, myocardial contractility will decrease, metabolic abnormalities will take place, immunosuppression will be there, secondary anti-inflammatory will be there, interleukin 10 will be activated. This interleukin 6, 8, PAF and ROS, they cause the systemic effects like fever and the vasodilation. So microvascular thrombosis, DIC, tissue ischemia, all these form and ultimately lead to multi-organ failure. Let's talk about stages of shock. So stages, if you see, shock is a progressive disorder that is, if uncorrected, leads to death. So unless the result is massive and rapidly lethal, Shock in those settings tend to evolve through three general phases: an initial non progressive phase, reflex compensatory mechanism, and activity. See, shock is a progressive disorder. If it is uncorrected, it will lead to the death. Okay, unless the result is massive and rapidly lethal. Shock in those settings tends to evolve through three general phases. One is initial phase. Here it is the initial phase is not a progressive phase. There is a reflex compensatory mechanism activated, and there is a perfusion of vital organs maintained. The perfusion to vital organs is maintained, like a brain, kidney, and heart. Talking about the progressive phase. In this progressive phase, there is a tissue hypoperfusion, onset of worsening cardiovascular and metabolic imbalances, including lactic acidosis, will occur. Then there is an irreversible stage, severe cellular and tissue perfusion. Survival is not possible even if hemodynamic effects are corrected. So there is this irreversible stage where there is a severe cellular and tissue injury. Survival is not possible even hemodynamic effects are corrected. So talking about the morphology. Talking about the morphology. So in morphology, what will happen? There is a cellular and tissue damage induced by cardiogenic and hypovolemic shock, that is hypoxic injury in brain, heart, adrenals, kidney, and GIT. Adrenal changes, cortical cell lipid depletion, conversion of relatively inactive vacuolated cells or metabolically active cells that utilize lipids to synthesize steroids. Kidneys active acute tubular necrosis. Changes in septic shock, lungs, diffuse alveolar damage is seen. Okay, diffuse alveolar damage is seen. There is a diffuse alveolar damage. Okay, disseminated intravascular clots are formed which cause fibrin-rich microthrombin in blood and brain, kidney, lungs, adrenal glands, and GIT. So here in septic shock, what will happen? The lungs diffuse alveolar damage is seen. Okay, there is a serosal surface and the skin particle hemorrhages with the exception of neuronal and myocytic ischemic loss. All other tissues may revert to normal if the individual survives. If the individual survives, everything will be normal. But if there is an injury to the nerves or injury to the myocytes, then it's not possible. Okay. Let's talk about the clinical features. Let's talk about the clinical features. So here, what is there? Hypovolemic and cardiogenic shock, hypotension, weak and rapid pulse, tachypnea, and cool, clammy, cyanotic skin are the clinical features. See, in morphology, you will see there is a damage to heart, cardiogenic, hypovolemic shock, hypoxic injury. You can see hypoxic injury. You can see. So there is the adrenal changes, cortical cell lipid depletion of relatively inactive vacuolated cells. And metabolically active cells utilize lipids to synthesize steroids. Kidneys, acute tubular necrosis. Lungs, diffuse alveolar damage is seen. Disseminated DIC is seen. Serosal surface of skin, particle hemorrhages can be seen. Okay, now hypovolemic and cardiogenic shock, hypotension, weak pulse, tachypnea, cool, clammy, and cyanotic skin can be seen. Septic shock, initially skin may be warm, flushed due to peripheral vasodilation. Initial phase, there is a rapid, what will happen in the initial phase? There is a rapidly cerebral, cardiac, and pulmonary dysfunction sets in. Metabolic acidosis and electrolyte imbalance disturbances worsen the condition. Second phase is the patient survives. There is a renal insufficiency, progressive fall in urine output, severe fluid electrolytic imbalance. Prognosis: hypovolemic shock. 90% of young, otherwise healthy patients survive with appropriate management. Septic shock and cardiogenic shock associated with extensive MI, high mortality rates, even with the state of the art care. So prognosis here is hypovolemic shock. 90% of young, otherwise healthy patients survive with appropriate management. Okay. Septic shock and cardiogenic shock associate extensive MI, high mortality rates with the state of the art care. So here metabolic acidosis and electrolyte disturbances worsen the condition rapidly. Cerebral, cardiac and pulmonary dysfunction sets in. Talking about short notes on morphology of the infarcts, this later we'll discuss. So this is about the septic shock. Let's talk about, is there any other shot given? Not given. So shock is a state with diminished cardiac output. In Hirschman, it is very well given. I suggest you to see from Hirschman itself. So, in septic shock, what is there? There is an endothelial activation. There is inflammatory as well as counter-inflammatory responses. There is an induction of procoagulant state. There is induction of procoagulant state. Okay, there is the induction of the procoagulant state. There is the induction of the procoagulant state, and formation of DIC and all will be seen. Metabolic abnormalities are there. Metabolic abnormalities are seen along with the organ dysfunction. Organ dysfunction is seen. Organ dysfunction is seen. Organ dysfunction is seen. There is the organ dysfunction. There is the organ dysfunction seen. Inflammatory as well as non-inflammatory things can be activation is there. There is counter-inflammatory response and inflammatory response. Endothelial activation, injury. Okay, endothelial activation, injury is there. So, shock is the clinical syndrome of cardiovascular collapse characterized by an acute reduction of effective circulating blood volume, hypotension, and inadequate perfusion of cells and tissue. Hypoperfusion. There is a hypoperfusion. There is a hypotension because of the decrease in the effective blood volume circulation and inadequate perfusion of the cells of the tissues. So shock are of different types, like you have hypovolemic shock. The hypovolemic shock, see, the hypovolemic shock can be due to the hemorrhage, the hypovolemic shock can be due to hemorrhage, it can be due to trauma, it can be due to trauma, it can be due to surgery, it can be due to surgery, it can be due to burns, it can be due to burns, it can be due to dehydration. See, what will happen if there is a severe dehydration and get cholera? So what will happen? The volume will decrease. In burns also, all volume will decrease. Surgery, if there is a huge blood loss. Trauma, volume will decrease. Hemorrhage, volume will decrease. Okay. So this is hypovolemic shock. So this is example of hypovolemic shock. What will happen? The effective circulating blood will decrease. Then what will happen? There is a venous return to heart will decrease. Then cardiac output will decrease. The blood flow will decrease. The supply of oxygen will decrease. There is anoxia. There is inflammatory mediators, and there is a shock. The next is the cardiogenic shock. Cardiogenic shock. Cardiogenic shock. In cardiogenic shock, there is a deficiency of emptying, or maybe there is a deficiency of filling, or there will be outflow obstruction. The heart is not working due to the myocardial infarction, due to ventricular arrhythmias, ventricular arrhythmias. So what will happen? Arrhythmias, it cannot empty easily, like only it is not filling and it is not emptying, so the cardiac output will decrease due to cardiogenic shock, or maybe there is a obstruction to the outflow. There is deficiency of emptying or deficiency of filling. Okay, talking about next is septic shock. In septic shock, you will find first there is a gram positive infection and followed by gram negative and fungal infection. So septicemia can be due to gram positive, they can be gram negative. What will happen septic infection if it is there? The effective circulating blood volume will decrease because of the severe vasodilation, all the blood comes into the spaces, and the venous return to heart will decrease. Because of the return, cardiac output will decrease, blood flow will decrease, supply of oxygen, anoxia, inflammatory response, shock. Other types are traumatic shock, neurogenic shock. There is hypoadrenal shock. Hypoadrenal shock. Okay, so let's talk about the shocks. The definition is it is a life-threatening clinical syndrome. It is a life-threatening life-threatening clinical syndrome. It is not a disease, it's a group of symptoms called syndrome of cardiovascular collapse. There is a cardiovascular collapse. There is acute reduction of effective circulating blood volume. It means there is a hypotension. The circulating blood volume will decrease. There is a hypotension. Blood pressure will fall down. There is a inadequate tissue perfusion called tissue hypoperfusion. There is a hypotension and hypoperfusion. There is a hypotension and hypoperfusion. So, guys, remember this. There is a hypoperfusion. There is a hypoperfusion. Okay, there is a hypoperfusion. There is a hypoperfusion and there is a hypotension. Okay, there is a hypoperfusion and hypotension. Talking about classification, so shock can be divided into hypovolemic shock, hypovolemic shock, okay, hypovolemic shock, hypovolemic shock. Again, so there is a hypovolemic shock, okay, and there is a cardiogenic shock. There is a cardiogenic shock. So there is a cardiogenic shock. There is a cardiogenic shock. There is a septic shock, and there is a other types of shock, in traumatic shock, neurogenic shock, hypoadrenal shock. So these are the types of the shock. So there are different types of the shock. Talking about pathogenesis, in general, all forms of shock involve three derangements. One is reduce effective circulation. Because of that, the blood pressure will form hypotension. There is a reduced supply of oxygen to the cells, okay, with resultant anoxia. And there is inflammatory mediators and toxin released from shock induced cellular injury. There is a inflammatory mediators released. So three things takes place. One is decrease in effective circulating blood, leading to hypotension. Other is decreased supply of oxygen to the tissues and cells, leading to anoxia. Other is inflammatory mediators and toxins released from shock induced cellular injury. ठीक है ना, हो गया. Then talking about reduce effective circulating blood volume. So reduce effective, it may be due to actual loss of blood volume as occurs in hypovolemic shock, or by decreasing cardiac output, or by decreasing cardiac output without acute loss of blood, that is normovoluminous, occurs in cardiogenic shock and septic shock. So loss of blood हो रहा तो it is hypovolemic shock. Hypovolemic shock. Cardiogenic shock in cardiac output is less. Cardiac output is less, even the blood is normal. That is normovolumic state is there. Normovolumic state is there. Normovolumic state is there. Even then, it is down. It means what is going on here? Two things. One is maybe there is a issue with the heart. It is not pumping, cardiac shock, or it can be due to septic shock. So two possibilities are there. Okay, let's talk about the impaired tissue oxygenation. So following reduction in the effective circulating blood volume from either of the above two mechanisms or from any etiological factor, that is decreased venous return. So venous return is decreased. Because of this, venous return is to the heart is decreased, resulting in cardiac output decreased cardiac output. So this consequently causes reduced supply of oxygen to organs and tissues, and hence anorexia is taking place. Talking about inflammatory mediators. Talking about inflammatory release of inflammatory mediators. Release of inflammatory mediators in cellular injury. Innate immunity of the body gets activated. A body defense mechanism causes release of inflammatory, but eventually these agents themselves become the cause of cell injury, like endotoxins, like endotoxins released from the bacteria. Endotoxins, endotoxins, endotoxins. There is a endotoxins release, and what is there is a endotoxin release in the bacterial wall in septic shock. This stimulates massive release of pro-inflammatory mediators, cytokines. So because of the release of endotoxin, there is a pro-inflammatory mediators releasing the cytokines, because of the cytokines. But a similar process of release of other agents takes place in late stage of shock. Other causes. So several pro-inflammatory mediators are released, like monocytes, macrophages, other leukocytes, and other body cells. The most important being cytokines, tumor necrosis factor, TNF alpha is released. TNF alpha and interleukin 1. Interleukin 1 is responsible for fever. Interleukin 1. Okay, so after these general comments on mechanism and shock features are seen. So see, sometimes in inflammatory mediators, the endotoxin released from the bacteria, the endotoxins released from the bacteria, what they cause? Pro-inflammation, because of the cytokines are released, because, like the interleukin 1 and TNF alpha. Okay, now let's see the pathogenesis of a shock. Hypovolemic shock. Pathogenesis of hypovolemic shock. Pathogenesis of hypovolemic shock. So what is happening here occurs from inadequate circulating blood volume due to various causes, most often uh, loss of red cell mass due to hemorrhage, and therefore also called as hemorrhagic shock. The major effects in these are due to decreased cardiac output and low intracardiac pressure. The severity of clinical features depends upon degree of blood volume. So major clinical features are increased heart rate. So there is a less blood, but still heart is pumping the less blood very fastly. So there is increased heart rate called as tachycardia. Low blood pressure is the hypotension. Low urinary output, oliguria or anuria, not all urine. And alteration in mental state, agitation to confusion to lethargy can occur. So what is happening? The volume is less, but heart rate is increased, as well as there is a tachycardia. Tachycardia means increased heart rate. There is a decreased blood pressure called as hypotension. So in all shocks you can see there is a hypotension. So there is a decreased volume. Because of the decreased volume, what is happening here? There is a heart rate is increased. There is a tachycardia. There is a hypotension. There is a hypotension. There is a hypotension. So there is a heart rate is increased here. Heart rate is increased here, and there is a hypotension. There is a tachycardia. Now let's discuss about pathogenesis of cardiac shock, cardiogenic shock. So in cardiogenic shock, there is a decreased cardiac output. So there is a decreased cardiac output. Why there is a decreased cardiac output? Because the heart is not able to pump. Maybe due to severe left ventricular dysfunction from various causes like acute myocardial infarction. MI can be the cause. Okay, and it effects in the form of decreased tissue perfusion and movement of fluid from pulmonary vascular bed into pulmonary interstitial space. Initially interstitial pulmonary edema, later into alveolar space, alveolar pulmonary edema. What will happen? This is your heart. These are here the right and left. Okay, left is more thicker. The left is more thicker. Okay, when compared to right. So this is your left ventricle. Okay, so what is happening here? What is happening here? Here, what will happen? The left ventricle fails to pump. Left ventricle is failed to pump. Then what will happen? All blood will go into the lungs. All blood will go into the lungs, and here the accumulation of the blood is there. Here the accumulation of the blood is there. Then here what will happen? Here edema will occur. Interstitial pulmonary edema. Later into alveolar spaces, alveolar pulmonary edema. Okay, so this thing is happening. Now I'm talking about pathogenesis of septic shock. Septic shock is somewhat just tricky. Okay, as we were discussing. So what will happen initially? Initially, what will happen? Host responses. There is some microbial product. There is some microbial product. There is some microbial product. What will happen? That is PAMPs. PAMPs, that is pathogen associated molecular patterns. Pathogen associated molecular patterns. Okay, pathogen associated molecular patterns are there. This is the initial host response. So what will happen? So lysis of microbial cell wall release microbe derived molecular products. So when there is a pathogen and the pathogen is destroyed, and what will happen? The microbial products are released into the body. So lysis of microbial cell wall release microbe derived molecular products, lipopolysaccharides, peptides into circulation. These products are called pathogen associated molecular patterns. So these are recognized by pattern recognition receptors on the surface of the monocytes. So we have a monocyte here. Okay, these monocytes are there. What they will do? They will recognize it. Recognize the receptors on the surface of the monocytes, macrophages, neutrophils. Okay, so these are the toll-like receptors. So toll-like receptors which bind to the molecular, that is bacterial products. Okay, so toll-like receptors are there. What will happen? The bacteria will bind to the toll-like receptors. The bacterial products will bind to the toll-like receptors. Then there is a G protein coupled to receptors and NOD1 and NOD2 nucleotide oligomerization domains protein which recognize bacterial peptides. So in the here there is a NOD1 and NOD2. These are NOD1 and there is a NOD2. So there is a NOD1 and there is a NOD2. So these G protein coupled receptors, NOD1 and NOD2, what they will do? They will identify it. They will recognize the bacterial peptide. So the complex of PMP receptor transduces recognition signal to the interior of the cell to trigger production of pro-inflammatory mechanism. Now, what will happen? These monocyte or macrophages, they will identify that these PAMPs, these are the bacterial products, because there is a complex form between the PAMPs, and that is pathogen associated molecular patterns, and the toll like receptors. So what will happen? They transduce recognition signal to the interior of the cell. Okay, and this what they will do? They will release the pro-inflammatory products. Pro-inflammatory products leading to pro-inflammatory mechanism. Subsequent events will occur. So now what will happen? Pro-inflammatory products will be released. Pro-inflammatory products will be released from these monocyte. I hope this much is clear. So what is happening here? What is happening? There is a microbial PAMPs. Okay, what is PAMPs? PAMPs is nothing but pathogen associated molecular patterns. So what will happen? When the microbe is digested, the cell wall is broken down. There is a release of the microbial products. What are the microbial products released? What are the microbial products released? LPS lipopolysaccharides, and there is a release of peptides. Then what will happen? The antigen recognizing are there na? That is monocytes, macrophages. Pattern recognition receptors are there na? Monocytes, macrophages, pattern recognition receptors on the surface of monocytes. So these are the toll-like receptors are present. These toll-like receptors bind to these PAMPs, they form a complex. So this is identified the G protein coupled receptors, node 1, node 2, and they will recognize the bacterial peptides. The complex form will send a signal to the cell. They will release the pro-inflammatory products. Okay, and to pro-inflammatory mechanism and signal transduction. Okay, now what will happen? The next step will take place. Already initial step took place. Okay, now second step will take place, that is activation of macrophages and neutrophils. So these pro-inflammatory cytokines which are released from the pattern recognition receptors, what they will do? What they will do? The activation of macrophages and neutrophils. Activation of precipitating cells stimulate pro-inflammatory cytokines, that is TNF alpha and interleukin 1. Okay, other inflammatory mediators such as high mobility group box 1 is released. This protein is released. Chemical mediators of lipids such as prostaglandins and platelet activating factor is released. These are released, and generation of reactive oxygen species to kill the pathogen. Okay, so see, in second step is the activation of macrophage and neutrophils. Okay, so because there is activation of precipitating cells and they stimulate pro-inflammatory cytokines. So these are the pro-inflammatory cytokines, TNF alpha and interleukin 1, and these are the HMB1 is the other inflammatory mediator, and you have PG and PF and ROS as the chemical mediators, and there is a generation of reactive oxygen species. So these are the pro-inflammatory, these are the other inflammatory mediators, these are the chemical mediators of lipids, and these are the reactive oxygen species. So these are the activation of macrophage and neutrophils occur due to these things. Okay, activation of complement pathway now. Okay, activation of complement pathway. What will happen here? So here what will happen? Activation of complement pathway. The cascade complement is activated by pathogen associated molecular patterns and forms C5A. It is a chemoattractant, and C3A. This is anaphylatoxin, and C3B. It is a opsonine. The end products of complement activation activate endothelial cells and further induce pro-inflammatory cells. Okay, so this is the third step, this activation of complement pathway. So this C5A, what are these? These are chemoattractants. They will attract the and go to the site. C3 is anaphylatoxis. They cause anaphylaxis. C3B, C3B. These are the opsonin. These are the opsonin. Okay, so these are there. So C5A, C3A, C3B. C3B, B को उल्टा करो P. This is a opsonin. A for anaphylaxis. C5 is a chemoattractant. Okay, these are the the end products of the complement activation. What they will do? They will not sit quiet. They will activate endothelial cells. What the endothelial cells will do? Procoagulatory state they will activate. See, activation of endothelial cells. What will happen? Pro-inflammatory process activity and lead to edema. So, if endothelial cells are activated, what they will lead to? Edema. Due to widespread of the leakiness. Okay, release of cytokines will be there. Interleukin 6, 8, and PAF, platelet activating factor. Then production of ROS, reactive oxygen species will be there. So endothelial cells if activated they will cause edema, interleukin 6 and 8 activation and ROS. Now activation of procoagulant pathway. What will happen? Coagulation pathway is activated by what factor? Decrease the production of anticoagulant factor by endothelial cells such as thrombomodulin protein C. Decreased production of anticoagulants are decreased. That's why it is becoming procoagulant state because uh, anticoagulant factors by endothelial cells such as thrombomodulin and protein C. So thrombomodulin and protein C. These are what? Anti. These are anti. These are anticoagulate. But these release are suppressed by the proagulant by the microbial products. Okay. So there is impaired fibrinolysis due to increased plasminogen activator inhibitor. There is a impaired fibrinolysin. Impaired fibrinolysis. Impaired fibrinolysis. The fibrin lysis will be impaired. There will be more fibrin due to decreased plasminogen activator inhibitor. So the net result of above mechanism is increased vascular permeability, profound peripheral vasodilation, pooling of blood causing hyperdynamic circulation septic shock in contrast to circulatory fall and hypovolemic and cardiogenic shock. Reduced blood flow produces hypotension, inadequate perfusion of cells and tissues, finally leading to organ dysfunction, development of disseminated intravascular coagulation with conceptic coagulopathy is an important end result of septic shock. So, what are the pathophysiology? There are three steps. One is compensatory phase. There are three phases. One is non-progressive compensatory phase. This is the initial or the early stage which is reversible. Then progressive decompensated stage. Then there is the irreversible stage. Now, no use of treatment. Compensatory phase, progression, okay, and irreversible state. Compensatory and non-progressive initial phase or non-progressive phase. So there is a wide spread of first initial leak in compensated phase. There is a vasoconstriction. So the fluid conservation by the kidney is there. Kidney will conserve the fluid. Stimulation of adrenal medulla. Because of this, what will happen? tachycardia. Okay, and there's a cool clammy skin. So in early stage of shock, attempts to maintain adequate cerebral and coronary blood supply by redistribution of blood to vital organs like brain and heart, adequately reperfused and oxygenated. This is achieved by activation of various neurohormonal mechanisms causing widespread vasoconstriction, fluid conservation by kidney. If the condition that caused the shock is adequately treated, the composite mechanism may be able to recover and re-establish the normal circulation. This is called compensatory or reversible phase. The compensatory mechanism are as under widespread vasoconstriction, fluid conservation by kidney. So there is a reduced GFR due to arteriolar vasoconstriction. So shifting of tissue fluid into the plasma due to lowered capillary hydrostatic pressure. In response to low cardiac output, adrenal medulla is stimulated to release excess of catecholamines, which increase heart rate and tachycardia. Why tachycardia is happening? Because of the stimulation of the adrenal medulla. In response to low cardiac output, and adrenal medulla is stimulated to release catecholamines, which causes increased heart rate. Okay, progressive decompensated shock. In this decompensated shock, in decompensated shock, what you will see pulmonary hypoperfusion. Lungs को you're not giving oxygen. There is a tissue ischemia. There is a lactic acidosis, metabolic lactic acid. pH will fall down. Okay. In irreversible, what will happen? Irreversible, they are irreversible. It is decompensated irreversible. Second step is compensated decompensate progressive. Third is irreversible decompensated. So progressive vasodilation. First step in compensated shock, it was vasoconstriction. Here there is vasodilation. Vascular permeability will increase. Myocardial depression factors. Progressive fall in blood pressure and permanently released blood flow to myocardium. Reduced blood flow to the myocardium causes coronary insufficient myocardial ischemia due to release of myocardial depression factors MDF. The resultant further depression and worsening of pulmonary hypoperfusion. Okay. Further pulmonary hypertension causes respiratory distress due to pulmonary edema, tachypnea, and adult respiratory distress syndrome (ARDS). Anoxic damage to heart, kidney, and brain. Hypercoagulability of blood. So, kidney will be damaged, adrenal necrosis, hemorrhagic gastroenteropathy, liver necrosis, blood may DIC. So thromboplastin release of platelet, all this will occur. Okay. So clinical features and complications. So there is a very low blood pressure because of vasodilation, subnormal temperature or maybe fever, and feeble and irregular pulse. Pulse is irregular here. Pulse is very irregular. Shallow and sighing respiration. Acute respiratory distress syndrome. DIC. Renal failure. Multiple organ dysfunction. Multiple organ dysfunction syndrome, acute renal failure can occur. Revising about shock. Shock is a clinical syndrome characterized by fall in blood pressure causing hypotension, fall in oxygen, that is hypoperfusion. Okay, two things. There are three major forms of shock: hypovolemic shock, cardiogenic shock, septic shock. Septic shock. Okay, three. In hypovolemic, you can list out the reasons. Okay, cardiogenic, you can list out the reason. Septic, you can list out the reason. Okay, all forms of shock involve three basic mechanisms. There is a impaired tissue oxygenation, effective circulating blood volume will decrease, and release of pro-inflammatory mediators. Pathophysiological shock is learned under three stages: uh, compensatory phase, which is reversible, decompensatory, progressive decompensatory, and irreversible decompensatory. Shock causes morphological changes in different organs, notably in brain, hypoxic encephalopathy, heart, hemorrhage, and necrosis, lungs, adult respiratory distress syndrome, kidneys, tubular necrosis, acute renal failure can occur, necrosis of adrenals, hemorrhage, liver, focal necrosis, gut hemorrhage, gastroenteropathy, and other organs. So, clinically, shock is characterized as low blood pressure, low body temperature, feeble pulse, shallow respiration, clammy skin. But in septic shock, there is a fever because of the release of the cytokines, interleukin 1. So, this is about the shock. Coming to our next question: neoplasia definition, benign and malignant tumor differences, and mention the modes of spread of malignant tumors with example. Tumor suppressor genes you have to talk about. Okay, let's search about neoplasia. So in neoplasia we have to talk about what? In neoplasia we will be talking about definition, difference between benign and malignant tumor definition. Okay, this one, this one, and this one. And what definition benign malignant tumors, modes of spread of malignant tumor with examples. Tumor suppressor, chemical, carcinogen, physical, biological pathways of spread of tumor, modes of spread of tumor, and tumor suppressor genes, tumor markers, retinoblastoma, Warburg effect, P53, and we'll be talking about paraneoplastic syndrome. Okay, let's begin. So, first, let's begin with the definition of neoplasia. So neoplasia means new growth. Neoplasia means what? New growth, defined as disorder of cell growth that is triggered by a series of acquired mutations affecting a single cell and its clonal progeny. So neoplasia is a disorder. It's a neoplasia. Neo means new. Plasia means growth. There is a new growth which is seen. There is a new growth which is seen, and because of this new growth there is a problem. Okay, so neoplasia is a new growth defined as disorder of cell growth that is triggered by a series of acquired mutations affecting signals. So here the cell growth is even there after removal of the signal which is causing it. Okay, after removal of the signal which is causing it. So neoplasia is a tumor is a mass of tissue formed as a result of abnormal, excessive, uncoordinated, autonomous, and purposeless proliferation of cells, even after removal of growth stimulus which caused it. Okay, that is the exact definition. It's a mass or tumor is a mass of tissue formed as a result of abnormal. So abnormal. So abnormal, excessive, in excess, which is not required, in uncoordinated manner, autonomous, and purposeless proliferation of cells. So, molecular basis of cancer. So, no lethal damage lies at the heart of carcinogenesis. Carcinogenesis results from accumulation of compensatory stepwise manner complementary mutations. Tumor is formed by clonal expression of single precursors that are genetically damaged. So carcinogenesis results from accumulation of complementary mutations stepwise manner. Tumor is formed by clonal expansion that are genetically damaged. Four classes of regulatory genes: growth promoting genes, growth inhibiting, tumor suppressing genes, genes regulate apoptosis, genes involved in DNA repair. So cellular, molecular, and molecular hallmarks of cancer: self sufficiency. So these are the hallmarks of cancer: self sufficiency, insensitive to growth inhibitory signal, altered cellular metabolism, evasion of apoptosis, ability to evade host immune response, ability to invade metastasize, sustain angiogenesis, limitless replicative potential. Oncogenes have the ability to promote cell growth in the absence of normal growth promoting signal. Encode a protein called oncoprotein. Proto-oncogene mutation. Oncogene. Oncogenes can be one of the genes controlling the functions. Okay, so these are the hallmarks. First is the self-sufficiency. Self-sufficiency growth signal. It does not require any growth signal. It will grow by itself. Okay, insensitive growth inhibitory signal. Insensitive to the growth inhibitory. Altered cellular metabolism is altered. There is no apoptosis. To evade host immune response, can escape from the host immune response. Ability to invade and metastasize. It can invade other cells and metastasize. There is a formation of new blood supply, angiogenesis, limitless replicative potential. So eight hallmarks are there. One is self-sufficiency of growth signal. It does not need any growth signal. Insensitive to growth inhibitors. It does not need growth signal. It does not react to the inhibitory signal. It has altered cellular metabolism. There is no apoptosis. There is no immune response effect on it, and there is the invade and metastasis. The ability to invade and metastasize, angiogenesis, and limitless replicative potential. First thing is self sufficiency. Second is insensitive to growth signal inhibitor. Am I live? No one is watching. Okay, so self sufficiency, insensitive to growth inhibitor. There is altered cellular metabolism. Okay, it is no need of growth signal. It will not respond to inhibitory, insensitive to inhibitory growth signals, and alters cellular metabolism. It escapes from the apoptosis. It escapes from the immune response. It can invade and metastasize, sustain angiogenesis, and limitless replicative potential. Once again, what are the eight hallmarks of cancer? Self sufficiency. It can it does not need any growth factors. Self sufficiency to growth factors. Second is insensitive to the growth inhibitory signals. Insensitive to growth inhibitory signals. Insensitive to growth inhibitory signal. Third is what? Insensitive to growth inhibitory signal. So these are insensitive to growth inhibitory signal. These are insensitive to growth inhibitory signals. So these are insensitive to growth inhibitory signals. These are insensitive to growth inhibitory signals. These are insensitive to growth inhibitory signal. These are self-sufficient, insensitive to growth inhibitory signal. These are insensitive to growth inhibitory signal. The third point is altered cellular metabolism. Cellular metabolism is altered. What is the next one? It escapes from apoptosis. It evades from host immune response. 1, 2, 3, 4, 5 is done. More 3 are required. The remaining are the sustained angiogenesis. Seventh one is there is angiogenesis, limitless replicative potential. Limitless replicative potential. It can invade and metastasize. It can invade and metastasize. These are the eight hallmarks of the neoplasia or cancer. Okay, self-sufficiency to growth factors, insensitive to growth inhibitory factors, altered cellular metabolism, it invades apoptosis, it invades host immune response, okay, it evades and escapes, okay, sustained angiogenesis, limitless replicative potential, invasive ability to invade and metastasize. Okay, so these are the hallmarks of the neoplasia. What is neoplasia? Neoplasia is a new growth. It is mass of cells or tumor cells. It's a tumor which is abnormal, excessive, uh, uncoordinated, autonomous, and purposeless proliferation of cells even after the removal of the stimuli which caused it. Okay, this is neoplasia. So, neoplasm may be benign or it can be malignant. We will see the differences. All tumors have two basic components, one is parenchyma and one is the stroma. Parenchyma comprises of proliferating tumor cells and supportive stroma composed of fibrous connective tissue and blood vessels. The tumors are named with suffix oma. Benign tumors are named with suffix oma with some exceptions. Okay. Malignant tumors of epithelial origin are called epithelial origin carcinoma. Mesenchymal origin, which are cancerous metastatic sarcoma. Mixed tumors, teratoma, blastoma, hamartoma, and choroiditis. So benign are the oma. Metastatic is two types. Benign are the oma, metastatic two types. If they are epithelial origin or mesenchymal origin. Okay. Oncogenes. Oncogenes, they have the ability to promote cell growth in absence of normal growth promoting signal. They encode a protein called oncoprotein or proto-oncogenes. There is a mutation. There is the first proto-oncogene. Proto-oncogene is silent. Okay, but what happens? Mutation takes place. Mutation after mutation, it will convert into a dangerous oncogene. So oncogenes can be one of the genes controlling the following function. So oncogenes, growth factor receptor, protein 1, signal transduction, regulatory protein, cell cycle regulators. So growth factor, proto-oncogene, PDGF beta, overexpression, astrocytoma, HST, bladder, breast cancer, TGFA, overexpression, astrocytoma, HGF, overexpression, buttercellular carcinoma. Growth factor receptor, ERBB1, ERBB2, adenocarcinoma of lung and breast cancer, ALK, adenocarcinoma of lung, point mutation, multiple endocrine neoplasia, MEN2 syndrome, medullary carcinoma of thyroid, signal transduction, RAS, NRAS, melanoma, Noma, KRAS, colon cancer, HRAS, bladder cancer. H is associated with bladder. BRAF, translocation mutation, melanoma, leukemia. Chronic myeloid leukemia and chronic acute myeloid leukemia. JAK2. Nuclear educators, regulatory proteins, CMYC, NMYC, LMYC. Amplification, bucket pneumonia, neoplasma, small cell lung carcinoma. So chemical carcinogens have two types: direct acting and indirect acting. Direct acting, they do not require metabolic oxidation. Example: anticancer drugs, cyclophosphamide and nitrosurias and beta propionlactone. Require metabolic activation is polymorphic CYP450, benzopyrene, benzidine, aflatoxin, and glycofulvin. There are two types. Directly acting, they do not require metabolic activation. And indirect, they require metabolic activation like benzopyrene, benzidine, aflatoxin, glycofulvin. Glycofulvin is antibiotic. So mostly by highly polymorphic CYP450 dependent monooxygenase. Okay, about physical carcinogens. Physical carcinogens are non-radiating and radiation is being based. Non-radiation mechanical injury, stones in gallbladder, urinary tract, healed scars, risk of carcinoma. Asbestos has been associated with some tumors of lungs, malignant mesothelioma of the dura. Radiation induced well known carcinogen, most frequently radiation cancer, myeloid leukemia. Breast and lung lymphoid tissue. There is UV light, less sensitive to radiation, squamous cell, basal cell, and malignant melanoma. Basal cell carcinoma, malignant melanoma, squamous cell. These are radiation induced because of the UV rays. Types of radiation: ultraviolet and ionizing radiations. Let's talk about differences between benign and malignant. Okay. So benign is a tumor said to be benign. It is localized, will not spread to other sites. It will not spread to other sites. It is there in its own location. Malignant tumors can invade. They do not stay in their homes. They invade and destroy adjacent structures and spread to distant sites. They go to other homes. They go to other cities. They go to other countries. So malignant are very malignant. They do not sit quietly. They break their homes. They break others' homes. They break cities. They move on to other country itself. But here benign one are very silent. They are in their own homes. Okay, benign tumors are designated by attaching the suffix oma. So there's oma to the name of the cell type from which the tumors originated. Tumors of mesenchymal cells follows this rule. So example: fibroma, chondroma, major malignant tumors. The same benign tumors, sarcomas, epithelial origin are called carcinomas. Sarcoma for mesenchymal origin and for epithelial carcinomas. Example: fibrosarcoma and chondrosarcoma. So benign tumors, well differentiated tumor and wide range of differentiation of parenchymal cells. Mystic cells closely resemble normal cell of eye. It may be not possible to recognize it as a tumor, so by examination of individuals as lipoma. The disease discrete lobules discloses the neoplastic nature of the lesion. Lipoma, leiomyosarcoma of the uterus. Lipoma and leiomyosarcoma of the uterus. Leiomyosarcoma of the uterus. Well differentiated tumors or low grade cancers. Well differentiated adenocarcinoma of the colon shows cancerous glands that are irregular in shape and size, invading the muscular layers of the colon. Squamous cell carcinomas of the skin. The tumor consists of cells which are similar to normal squamous epithelial cells, intercellular bridges and keratin pearls. So see, wide range of differentiation of mechanisms. So well differentiated tumors, low grade cancer. Well differentiated adenocarcinoma of the colon. It shows cancer scars that are irregular in shape and within the muscular layer of colon. Squamous cell carcinoma skin cells which are similar to normal squamous epithelium with intercellular bridges and keratin pearls. Poorly differentiated tumors, high-grade cancers, they consist of cells that are little resemblance to cell of origin. Moderate differentiated tumors, intermediate, high and low-grade cancer. These differentiation. So based on differentiation and based on the well-differentiated microscopic examination lipoma, the growth of cell to discrete lobules. Example, lipoma, okay, and leiomyoma of uterus. Okay, talking about growth, these are slow growing, these are rapid growing. Okay, local invasion, talking about it, no invasion, no invasion. Here, locally invasive infiltrate surrounding normal tissue. Surrounding normal tissue. Metastasis is absent, here frequent. Prognosis good, here very poor. Based on histological features, benign, growth organized, here disorganized. Nuclear morphology, uniform nuclei, normal. Normal to some hyperchromatic changes can be seen here. Nuclear polymorphism, hyperchromatia, chromasia, and irregular outline. Here, low NC ratio, high NC ratio. Rare normal mitotic figures. Here, high and abnormal mitotic figures. Lack of invasion present. Here, no metastatic potential. Here, hallmark is malignancy. Here, absent nuclei. Here, usual and prominent nuclei. Tumor germs is not seen, may be seen nuclear ATPI. Here, chromosome abnormality is not found, here seen. Maintain polarity, here loss of polarity. Based on gross appearance, these benign tumors are mostly circumcised encapsulated. Here, malignant are poorly defined. Here, areas of necrosis here common. Okay, talking about the tumor suppressant genes and mode of spread. Okay. Pathways of spread, lymphatic spread, hematogenous spread along body cavity, direct transplantation, and epithelial lining. I'm thirsty. I'll continue the video.